Who am I? I'm Martin Ansell. I'm an old age psychiatrist based at Collier's Court in Cinderford. And so I do a lot of the diagnosing and treating of older people with memory problems in the forest. So really going up from the M50 down to Chepstow and all areas in between. To make a start, I think the first thing is we talk a lot about sort of memory clinics and memory assessment services. And as people get old, they do tend to worry about their memories. And while dementia is certainly a cause of memory problems, there are a whole host of other things that it could be. And so if you do know people who are worried, I wouldn't advise you to get them to seek help, because it may well be something that's relatively common and easy to fix. So the things that you'll come across. So age, our brains change as we get older. One of the things that happens is that when you're young, so when you're a teenager and in your 20s, you keep coming across across problems you've never met before. So your brains work very much on a problem-solving basis and trying to work out new ways of doing things and are very, what we call plastic. So you're always making new connections. As you get older, there's a change in how your brain works, because you're not meeting new problems, you're just meeting problems that you've met before. And so you're relying on knowledge and wisdom. And so if you like, the brain becomes less plastic. And so you can often get problems with your memory. Terry Wogan was a great one for them, senior moments. It's the bit where you walk into a room and you forget what you've gone for. So these, to a degree, are common with age. The other thing that has a big part in modern life, particularly, is sort of stress and anxiety, and really just sort of being overworked and too busy. And that can have really sort of quite marked problems to your memory. Certainly my own is, I had promised to do a talk down in Bristol one Wednesday morning, and I'd phoned up the organisation on the Tuesday afternoon to confirm that I would be there and what was happening. And then it gets to Wednesday afternoon and I'm sat in my desk at hospital thinking, crikey, I shouldn't be here, I should be in Bristol this morning. And it had just gone entirely from my mind. And so these things can have significant effects. If you're depressed, you can have problems with your memory. People who are depressed, their thinking slows up, they don't take things in, they're too worried about things, and so things don't stick. People who have fibromyalgia, which is sort of also chronic fatigue syndrome, often complain of a brain fog, where thinking is just not quite clear and things aren't quite as they should be. Medications, certain medications can affect people's memories and their concentration, and it tends to be more apparent when you've just been started on something. And the common ones we come across are when you've been put on a strong painkiller. So something that's got a bit of sort of opiate in, like tramadol or morphine, that can affect people's memories. Other drugs, so illicit drugs and alcohol can affect memory. We know that people who are regular cannabis users, for example, can have problems with their short-term memory while they're intoxicated with cannabis, but also it can lead to permanent long-term damage later in life. Alcohol, there's a thing that's called same state learning. And it's when you're down at the pub, remember those days, and somebody tells you a joke and you sober up and you can't remember the joke for the life of you. But the next time you've had a couple of pints, it's straight back in your mind. So you tend to remember things better in the state that you were when you learnt them. There are various medical things that can cause memory problems. So people have a thyroid gland, a gland in the neck called the thyroid. And if that becomes underactive, that can affect people's cognition and their memory significantly. And some vitamin deficiencies can, particularly vitamin B12 and folate. What we are seeing now is, and it's probably a bit like the chronic fatigue and the post-viral fatigue syndromes, there are a number of people who've got long COVID who are complaining of this same brain fog, and their brain's not working quite properly. They're coming. The list is endless. There's all sorts of things that can affect your memory, and one of the jobs, if you like, of myself and GPs when you're diagnosing is to see if it's one of these, and then you can treat it appropriately. Okay, but if we do come on to dementia, which is what I'm talking about today, is we need to get some terms, I think, cleared up. because quite often people get, when they come to see me, are not quite sure what's the difference between Alzheimer's disease and dementia. And so it's just worth being clear. So dementia is a term that relates to a group of symptoms that affect the brain and your cognition. Okay, so dementia is a generic term that says there is something going on that affects your thinking, your cognition. And quite often that is memory, and particularly short-term memory, but not always. It can also affect people's orientation. So people become a bit more muddled up as to what the date is, and then perhaps to whereabouts they are. There's often problems with speech and language, so problems with talking. So that's often people will have difficulty in finding the words that they want, particularly nouns. So you may know you want a boiled egg, but the word won't come. So to speak, oh, you know, it's one of those round things, comes out of a hen, it's white and yellow. But also you can have problems with understanding. So that's sometimes understanding what's said to you. So quite often, if you have a degree of dementia, and maybe you're also a little deaf and your hearing aid's broken, or you've got some wax, then actually understanding what people are saying to you can be quite difficult. But also people can have more difficulty in understanding the world around them. And so it's often people will have difficulty in recognizing things. So for example, you get yourself the story was that a lady, her cooker had broken, and her son had bought her a nice new microwave to put in the kitchen. And I went to see her, and she was very pleased with this thing that her son had bought her, but it wasn't very good because she couldn't get a picture on it. And so it looked like a television. And so this understanding of what was what. The other thing that can sometimes happen is that people's understanding of nuance can go. So people can become very black and white in their thinking. Again, one of the examples is we must all have had those little leaflets that come through the door, or used to, from the Reader's Digest, saying that you have won £20,000 in a prize draw. And we all know that's not true, so they go straight in the bin without being opened. But I had a lady who was a patient of mine who was convinced she had one, and went and bought herself a new car on the strength of it, because actually she'd had a letter that said quite clearly that she had won £20,000. So it does mean that people can be more open to I guess, to being exploited and taken advantage of. People will often find that there's a change in people's personality. So if you've known someone, then sometimes they become either different, so you don't recognize them as the same person because their character traits change completely, or sometimes they just get worse, if you like. So if somebody was a bit sort of perfickety beforehand, they can become more so. So you can get exaggerations of underlying personality. So those are the symptoms, if you like, that affect the brain. But in order for it to be a dementia, they have to be of such a severity that actually they impact on your ability to function, on your ability to do things. Okay, so you can have a bit of a memory problem, and lots of people do, and they need to make a list to go shopping. But actually, as long as you're able to look after yourself and shop and can work around things, then you don't have a dementia. You need to have a combination of cognitive decline that leads to a deterioration in functioning. Okay, so you need these two bits. And also what we know about dementia is this doesn't happen quickly. This is a very insidious process, a gradual process that happens over a number of months and often years. And so often when we're looking at the course of dementia, we're talking to people, we say it's about, on average, sort of 12-year course. Some people it can be quicker, some people it can be much longer, but you say it's around that time from getting the symptoms. Okay, so that is the dementia. So the dementia itself is a syndrome. It describes a group of symptoms that have a certain effect. Okay. When we come on to things like Alzheimer's disease, we are looking at different types of dementia. Okay, so if we assume that dementia is a set of symptoms leading to a decline in function, that is caused by damage to brain cells. That is caused by brain cells dying off. Okay. When we look at the different types of dementia, what we're then looking at is what is causing the damage to the brain cells. What is happening in the brain that's causing the brain cells to die off, to give you these symptoms with your memory and your orientation, leading to you not being able to do things. Okay. And there's a list of, which I'll go through in a minute up there, of the common types. Okay. The picture's interesting. Whereas most young boys would have had posters of Chelsea Football Club, or maybe the Spice Girls on their bedroom walls, budding old age psychiatrists have the Munich 13. This was a group of scientists who were working in Germany at the turn of the 20th century, who include, if you like, the big names in neurology and dementia. So the chap with the red arrow would be the captain. He's Alois Alzheimer, the daddy of them all. But to the side of him, there's a young upstart. There's a chap called Frederick Louis. And Frederick Louis worked in the department and has his name associated with this dementia with Lewy bodies, because he was the chap who looked down the microscope at the post-mortem samples of brain cells and came across these little inclusion bodies that he called Lewy bodies after himself, because he was modest that way. Okay. So if we talk a bit about them, I'll talk basically what they are. So Alzheimer's disease is by far the commonest of the dementias and takes up, I guess, about 2/3 of cases. We talk a bit more about it later on in the afternoon, but it's largely a disease of the brain cells themselves. So something happens in the brain that causes the brain cells to die off, and there's various abnormal proteins. Vascular dementia isn't really a disease of the brain at all, particularly. It's a disease of your blood vessels in your heart. What happens in vascular dementia is that the blood vessels that carry the blood to the brain get clogged up, they get blocked, furred up like your pipes. And so no blood can get through, and therefore there's no oxygen, no nutrients getting through to the brain cells, so they die. And of course, the area of the brain where they die and the number and the size of the blood vessel that gets clogged up will give you different symptoms. Okay. Down at number 4 is what we really find, particularly with older people, is it's very rare that you just get one or the other. You tend to get what's called a mixed dementia. And certainly when they look at what are called post-mortem samples, so if people have donated their bodies to research and have their brains looked at after death, you often find mixed Alzheimer's and vascular damage to the brains. So it's likely that a lot of these cases are mixed and not just any one pure thing on its own. Dementia with Lewy bodies is a bit different and has an association with something called Parkinson's disease. So in Parkinson's disease, there is often it's often a movement disorder. So people with Parkinson's disease have a bit of a tremor and they sort of shuffle when they walk and stoop a bit. And if you have those symptoms and you have a dementia, so you have the cognitive problems, and you can have other symptoms like hallucinations, so seeing things that aren't there, then that you have a diagnosis of something called Lewy body dementia. The reason that that's important for doctors to recognize is that sometimes the medications that we use to treat hallucinations can make the Parkinson's disease worse. So they can make people more stiff, more shuffly, and more shaky. So it's important to get the diagnosis right because the treatments are slightly different. As sort of slightly rarer dementias, there is something that's called frontotemporal dementia. You may also come across it called FTD, which is just its initials, or sometimes Pick's disease. after a sort of a rival neurologist in a different team, Dr. Pick, who described it. That tends to affect younger people. So that's more a condition that affects people in their 50s and doesn't have such an effect on memory, but has a much bigger effect on people's personalities. So it's often missed and gets sort of written down sometimes as sort of a midlife crisis or maybe a depression or something else, because people aren't looking for dementia in younger people. There is something that they used to call alcohol dementia. Sometimes they call it Korsakoff's syndrome. I think it's probably better now referred to as sort of alcohol-acquired brain injury. So we know that if people drink a lot over a long period, it can give them a dementia-like syndrome. It can affect the brain to such an extent that they can't function properly. The difference about it is that if you stop drinking, then there can sometimes be some improvement. So I occasionally come across people I'm asked to see who were living at home, have got very confused and been admitted to a general hospital with something wrong with them, have been found to be really confused in the hospital and have been put in a care home. And then 6 months later, when they've not had anything to drink for 6 months and have had regular meals and all their medications in a nice structure, have improved significantly in their cognition and are really well enough now to go home, which is fine as long as the council haven't sold their home to pay for the care home. So again, it's there, and again, there's plenty of others and lots of rare things and subtypes, but they're the basic ones that we see 90% of the time. Okay, so we know that although unfortunately as yet dementia is not curable, we do know that if you can diagnose it early and you can start different treatments early, you can improve the outcome down the track. Okay, so people on all the sort of the tests and the studies that they do better and have a better quality of life for longer if you catch it early. Okay, so it's one of the reasons why people should come along rather than being terrified that there's nothing they can do, it's a death sentence. Okay, so diagnosis can take place in all sorts of different areas. It could be done by your GP. So GPs are able to diagnose at times. Sometimes it'll be picked up in hospital. Sometimes you find that people go into hospital with something else. I know they've had a fall and broken their hip and it gets picked up, or they've had an operation on their gallbladder or something and it gets picked up in hospital, or in a specialist clinic like I run at Collier's Court. But what happens basically is the same wherever you are in some form or another. The doctor or the nurse will do what we call take a history. So that's where we ask all about what's going on. So how long you've had a problem with your memory, what problems is it causing you, who's noticed it, does it stop you doing anything? So we ask all about what's happening now. We also ask questions to hopefully point us in the direction of what sort of dementia it is, whether this is Alzheimer's or vascular. So we'll ask about your medical history. We'll want to know what tablets you take. We will often want to know if you've got any history of dementia in the family. We then, in psychiatry, we take a life story from you. So we ask you about your life from your childhood right through to your adult life. Because one thing we know is that the experiences you have had in life, they sort of really sort of influence who you are as a person, and shape you. And so if your memory and cognition is not working so well, sometimes that will impact on how you feel about things and how you experience things in later life. So, for example, one of the sad things we often come across is that people who've had adversity in childhood, either they've been separated from their parents or lost a parent or been in children's homes, and have actually been able to put all that behind them while they've been at work and having families of their own, as they get into later life and their short-term memory is poor, they tend to get these memories from the distant past coming back stronger. And if you have spent a childhood in if you like, a less than ideal nunnery, and you end up in a nursing home with people who may well be nuns because they're dressed in uniforms, they look a bit like nuns, that could bring back all sorts of unpleasant, unhappy memories and emotions from childhood, which will affect how you are today. So it's important to get the history, the life story of the person. So we ask the patient all those questions, and then it's equally important to get what we call a collateral history. We would want someone who is a friend or a family member to also tell us how they thought things were going on, what they thought was going on, and what they saw the problems to be. And some of that is because one of the snags with having problems with your short-term memory is you don't actually always remember what problems you have been having because you don't remember them. And so having somebody around to say, this is what's going on, I've noticed this, that can be really helpful as well in getting the diagnosis right. People will have a physical health check, a physical check over, and a number of blood tests. And again, this is, if you remember the first slide, this is to rule out some of the physical things. So we'll do a full blood count to see if you're anemic and check your vitamin B levels. You'll have a test of your thyroid function to make sure your thyroid's working all right. We'll check your liver to make sure that you've not been drinking too much. So there's various sort of tests will be done to rule out causes. Part of the interview will be a cognitive test. And this is the bit you always see in the comedy programs where people want to know who the Prime Minister is. And there are a whole number of these things around, a whole lot of them. And I've just put the clock drawing one up for you because it just gives you an example of the sort of things that you can pick up with these tests. But the idea is that it gives us some form of objective evidence of where the cognitive deficits are and how bad they are. So on the whole, that the cognitive tests we do will tell us how different brain functions are working. So it can say, actually, your short-term memory is measured here, and your memory with a cue, with a prompt is like this. Your language is like this. Your visuospatial ability from the back of the brain is like this. So it gives us a clearer picture and an objective picture about how different bits of the brain are actually working. And also, because they tend to have a sort of an overall score, it will give us an idea about whether we're talking about sort of a mild problem, a moderate or a severe problem, or whether actually these minor deficits just fall within what would be normal for aging. So they're not diagnostic on their own, but they are quite helpful in giving us a clue as to whereabouts we are and what's going on. And I guess equally important is that they can also give us an indication of how people are responding to treatment. So you can do these things after a period of time and say, are things better? Are things worse? Are things staying the same? And it gives us an idea about how people do over a period of time. And quite often I have people coming to the clinic who've been concerned about their memory. I don't think have dementia, but I will say, well, come back in 12 months' time and we'll do the cognitive test again, and we can just compare to see if there has been any decline that you'd expect with a dementia or whether it's just the same. The other thing that pretty much everybody gets these days is a brain scan. So we'll take pictures of the brain. Oh, that's not what I want. That's what I want. Okay, so there are various different brain scans that people use. The commonest one, the one that people are most likely to get, is something called a CT scan, a computerized tomography scan. The CT scanner looks a bit like a big donut. And if you watch 24 Hours in A&E, or if you're sort of more risque A&E after dark, you will see that all the people who go to A&E these days get put through a scanner. In the big donut, there is a X-ray camera. on a sort of a track that goes round and round and round, taking X-rays at different angles. And so the computer then puts all these images together and gives you pictures like the ones that we've got on the screen. Okay. There is a different sort of scan that sometimes people have called an MRI scan, a magnetic resonance imaging scan. And that works in a slightly different way in that it doesn't use X-rays, it uses magnetic fields. The difference is that, one, it's probably more expensive to have. And secondly, it's not as pleasant, because rather than having just the donut, it's the one that's got the long claustrophobic tubing that you have to go into that bangs and rattles, and some people don't like it. And also, if you have little bits of metal in your head, so from cochlear implants for hearing problems, or if you've been working in engineering and have got little bits of metal in your eye, then you can't have it because it moves the metal around. Okay. The MRI can give clearer pictures. If you're thinking that the CT scan is your Polaroid Instamatic, then your MRI scan is your high definition 4G TV. So it gives us clearer pictures, but is more of a faff. And so often the CT is enough. What we're looking at here, if you like, is just to show you is that the top one is a scan of a normal brain on the right and a brain in somebody with Alzheimer's disease on the left. If we ignore the arrow for a minute, if you just look at it generally, so that sort of the brain is sort of the walnut shape in the middle, and I think you can see with the naked eye that the one on the left is shrunken. It's smaller, not as plump and juicy as the one on the right. And that's what they call generalized cortical atrophy. And it happens to us all as we get older, you'll be pleased to know. More importantly, in Alzheimer's disease, and I guess in early Alzheimer's disease, so when it's not particularly advanced, is where the arrow comes in. There's a bit of the brain called the hippocampus, which tends to shrink early on in Alzheimer's disease, so before the rest does. So we often use that. It's called a biomarker. So if somebody came along and they had some memory problems, they weren't scoring so well on the cognitive assessment, but actually they were still functioning pretty well and we weren't really sure, then having this scan with hippocampal atrophy, with a shrinkage of that little bit of the brain there, might point us in the direction of being Alzheimer's disease. Okay. The pictures, the one at the bottom, that's, well, I should say really, just for completeness, that the first pictures, if you look at me, are like you're facing yourself in the mirror. They're slices that way through the head, about level with your ears. The bottom one, the picture for the vascular damage, that's where your head's more like a boiled egg and people have taken the top off. So that's looking down on top. And again, what you see on the bottom one is you see round the outside, the sort of the white eggshell is the skull. The sort of the grey walnut is the brain. The black spaces are fluid spaces around the brain. And in the middle, there's a bit called your ventricles, which is meant to be there. The bit that's not right on this is the white patches. And so what has happened is that the blood vessels that supplied that bit of brain have got clogged up. And so the brain cells have died, and you'll see the residual scarring that's been left behind. Okay, so these are the sort of things that we're looking for when we ask people to have brain scans. We're looking to see if there's evidence of Alzheimer's disease or if there's evidence of cerebral vascular disease.
Martin,
okay.
Can I ask you a question?
Yes.
With the top two images, just to give people a perspective of time, how sort of progressed is the damage to the brain on the left? So
part of me says it doesn't matter. Okay. So one of the things we know that actually the actual amount of atrophy on its own, shrinkage, doesn't really matter. Okay. One of the snags that we have with doing brain scans is that you can sometimes see people who will have a brain on, like the one on the right, a lovely, plump, juicy brain, and yet clinically will have Alzheimer's disease.
Right.
Equally, you can have people who've got a brain like the one on the left, or even smaller, even more shrunk than that, whose cognition is absolutely perfect. Okay, so it's all a bit of a swindle on my part, in that we can't actually, the brain scans themselves aren't very good at telling us this person's got Alzheimer's, this person hasn't. Yeah, they are helpful in conjunction with the history that we've taken from people and the scores that we've got, if that makes sense.
So it's a combination of everything.
Yeah, yes. And so, you know, if you had a clear history that actually your memory had been rubbish and getting worse for the past 3 years, and you couldn't work the television anymore, and actually your spouse is saying, yes, no, he's certainly got a dementia, and you have a scan like the one on the right, I'm not going to say you've not got dementia. Yeah.
Yeah.
So they're there. And that's one of the reasons we tend not to do repeat scans, because what's one of the things that often patients and their carers will ask me is if somebody's known to have Alzheimer's disease, they'll say, should we have another scan to see how much worse it's got?
I see.
And you say, well, actually, no, because that won't tell us. Part of you know how much worse it's got, because you're living with them and you can see what they're like now compared to last year. The other way is, like you say, it's doing the tests that we do to say, you know, this was their clock last year, or they scored 30 out of 30 last year, and now they've scored 20 out of 30.
Thank you.
That makes sense.
Yeah.
Okay. The other thing,
Martin, can I just, before you go on, can I just ask, out of interest, on your vascular stroke damage, which part of the brain is damaged there? Is that obviously not the hippocampal, is it?
Yeah, no. So there's two bits that they have. So what they'd call that periventricular ischemic change, or sometimes they call it deep white matter. So if you look at that picture and sort of envisage in your head, you have two sorts of brain cell, if you like. You have Hercule Poirot's little grey cells, the thinking cells, and they tend to live around the outside of the brain. And then you have white cells, which is the cabling, the connections. And so this is really damaging to the cabling. And you often find it around the ventricles, so deep within the brain, because the blood supply comes up around the outside and then sort of dives down. And so it's there that they're getting it to their narrowest diameter. So they're more likely to get clogged.
Yeah, understood. Thank you.
Yeah. Okay. So sometimes these scans are enough and they give us everything we need to know. But sometimes, particularly if you've got younger people or not so severe syndrome, not such a severe dementia, and it's not, the picture isn't so clear, and the scans don't always help us, then they do have things that are called functional imaging scans. Okay. And so whereas the ones on the screen show you what the brain looks like, functional scans will tell you which brain cells are working and which aren't. And so the ones we tend to use are things called PET CT scans. Positron emission tomography, doesn't really matter, but what happens is you get a needle into the back of your hand and you get squirted with some radioactive sugar. Okay. You're then left to sort of read a book for a bit while the radioactive sugar swills around your system. The theory behind it is that brain cells that are working, they need the sugar, they need the energy to work. And so they will take up this radioactive sugar. And then if you have a special camera, they will glow. They'll glow nice and sort of red and yellow and orange. Whereas if your brain cells aren't working or are dead, they won't need any sugar. And so they won't take up this radioactive glucose, so they won't shine. And so that you can sometimes use that sort of test to either diagnose a dementia or to work out which type it is. And it's particularly useful if you're not sure whether it's a frontotemporal dementia, where the front of the brain isn't working, or whether it's Alzheimer's disease, where it's nearest to the back. So again, there are other types of imaging of camera available if needs be. Okay, so we've come on to treatments. As yet, unfortunately, there is no cure, but people are working at it. However, there are some things that we can do that are helpful. There's medicines, and that has its own special bit later on. But just education, just knowing what's going on is helpful. They did a study that they initially did in America, but have done it in England since. And that really said that even if you gave people no medicine at all, if all you did was you gave the patient and their loved ones 6 sessions of education, just talking a bit about what's going on and what support is available, those people were still at home 18 months longer than people who didn't have it. So people without any education, the course was that they would go into a care home, whereas just knowing what was going on and what you're dealing with meant that people could manage for much longer. So education is really important, as is practical support, you know, and that may be all sorts of funny things. It may just be, actually, I'm not driving anymore because of my Alzheimer's disease, my dementia. My wife never learned to drive. Oh yes, this is the dial-a-ride. This is a local taxi firm. You know, it's, oh, I can't quite manage this around the house. Yes, let's get you a PA or a home helping. So just having some practical support to manage things is really helpful. There's been a big sort of increase in technology and something called telecare that's really sort of taking off. And if I was young, I would just spend my time inventing things that are helpful. But there's a whole host of stuff, from things that will switch the oven off if you've left it on, things that will stop the bath from overflowing if you forget to switch the tap off because you've been distracted by something else, to things that you can attach to your door that say, don't go out, it's the middle of the night. There's a whole host of stuff, pill reminders that will ping and remind you to take your tablets. Okay. Having a diagnosis, it's not, I put financial benefits, which may not be quite the right term, because there's probably better ways to have financial benefits, but having a diagnosis does allow you to access various benefits that you're not allowed, that you can get. There's a reduction in people's council tax they can get. They may be eligible for some carers allowance or some attendance allowance. It also, of course, by catching it early, allows you to plan for the future. You know, it may be that the kids moved off to Australia and you've been planning to go and visit them on your golden wedding in 3 years' time. And you think, actually, let's do that sooner. Let's not wait. Let's make the holiday of a lifetime now. There's things like lasting powers of attorney that people can sometimes do, where they can sort of make sure that if in the future the time comes that they can't make their wishes known, that there's other people who can act on their behalves. And of course, there are a number of psychological treatments, which you'll have to write on. If you do get the talk, write it on, because it wasn't on the original one. And I felt terrible that I'd not put it on. So there's a whole lot of stuff, if you like. So the ones that have evidence, so there's something called reminiscence therapy, which is really helpful. We know that people's memory for the distant past is retained much better than day-to-day things. So actually being able to catch up with people and talk about things from the past is really helpful. It stimulates the brain and helps keep it ticking over. We know that music and smells are kept in very old, very ancient parts of the brain and are maintained. And so, like you saw before, so singing for the brain is really helpful. People will often remember all the words for songs when they can't remember words for anything else. And also smells are really helpful. You know, it's those sort of smells of the carbolic soap or whatever else they used to have in the olden days that can bring back memories flooding back for people. And of course, there is also room for, if you like, more, I guess, more psychological treatments. You know, having a diagnosis of dementia can clearly take some getting used to for people, and the changes to how they view themselves. And so there is sort of just talking treatments to allow people just to sort of understand a bit more about the changes that they're going through, and for their families to understand the changes that are happening to their loved ones. So there's a lot of psychological treatments that are very helpful. Okay, moving on, medicines. Okay, so there are a few medicines that have been invented for Alzheimer's dementia, but are also useful in Lewy body and in mixed dementia, not as so in frontotemporal or vascular dementia. Okay. The theory behind them is, I've put it down, a bit of theory. So we know that brains are made up of networks of millions of brain cells. So we've talked about the grey cells and the white cabling and all these networks of neurons that are met up. And they all talk to each other through having chemical neurotransmitters. So you'll have two brain cells, and one will squirt out some chemical which will stick to the other one, and that's how the message carries on. So there's all these neurotransmitters. We know that dementia, and whatever sort of dementia, it's killing off the neurons. The brain cells are dying. And so currently the treatments aim to increase the amount of available neurotransmitter that's there. So they're saying the brain cells that make these neurotransmitters are dying off. There's all these networks. How can we increase the amount of the chemicals that carry the messages to keep the remaining brain cells working? Okay, so that's what all the current treatments do. They unfortunately aren't doing anything to stop the neurons from dying. So we can't stop the process, which again is why it's worth catching things early, because actually, if you've got pretty good brain function when you get a diagnosis, then the medication can keep you at a pretty good level of brain functioning. I've written down in red the two sort of neurotransmitters involved. Acetylcholine is the one that's particularly involved with memory and Alzheimer's disease, but glutamate is another widespread neurotransmitter in the brain. And the tablets or the medicines are there: donepezil, rivastigmine, galantamine, and memantine. And they are all pretty good. They're not brilliant, but they're all pretty good at doing two things: bringing about a bit of an improvement. So quite often when people start taking them, they feel a bit better in themselves and their cognition, their functioning improves a bit. But the other thing they do is they slow the rate at which things get worse for as long as you're taking them. So again, they're worth starting early and persevering with for as long as they're beneficial, for as long as you're getting a good quality of life and they're helpful. Okay. There are other medicines that we sometimes use that aren't necessarily directly to treat the dementia, but are quite helpful. So one of the things, particularly in vascular dementia, is actually because the problems with the blood vessels and having these little strokes, you want to stop these blood vessels clogging up. And so the treatment is aimed at stopping that from happening. So it's controlling people's blood pressure, making sure sugars levels are under control in diabetes and that cholesterol levels are right. If you have low mood and anxiety, and certainly that's not uncommon in dementia, particularly early on, when everything's just that much more difficult and things aren't working quite as they should and the world becomes more difficult, then we often use antidepressants. Sometimes sleep can be a problem. And one of the bits that can sometimes happen is your circadian rhythm gets out of sync. And so people are often ready for bed at about 7 o'clock in the evening and then wide awake, ready to go up and off to work and start the day at 3 o'clock in the morning. So sometimes there are things like circadian down there that can help with sleep. We mentioned before in Lewy body dementia that people sometimes got these hallucinations. They would see things that aren't there. And that can happen in all sorts of dementia. And there are drugs called antipsychotic drugs, which were invented for schizophrenia, which are helpful in reducing hallucinations. The problem is that in dementia, they're found to have a slight increased risk of stroke and a slight increase mortality rate. So they're not 100% safe. And so they're really only used now, I guess, I'm going to say not as a last resort, but they're not dished out like Smarties as they were perhaps 20 years ago. And quite often, if people are having hallucinations that aren't particularly troublesome, then we don't always necessarily treat them. You know, I had a chap who saw ladies coming into his house and he wasn't particularly bothered. I thought at 86, if I have a stream of ladies coming into my house, I'd be quite happy. So we decided not to bother treating him. And as long as they behaved themselves, they could stay. Okay. And again, down at the bottom, I've just written the names of the tablets that you may come across. So mirtazapine and citalopram are modern antidepressants. Circadian is this thing to help with sleep. Lorazepam is quite a strong tranquilizer. It's a bit like a very strong Valium that can help with people who are very agitated, but does increase the risk of people falling over and can make them more muddly. And risperidone and haloperidol are commonly used antipsychotic drugs. I thought I'd just do a little bit about research. We've got just a few minutes left, so I thought I'd talk a bit about research. So this is mainly for Alzheimer's disease, and because that's the most commonest form of dementia, that's where most of the research is going. So the current theory is that actually the illness, the pathology, has started many years before you start to get symptoms. So for years before you start to lose your memory, the process of Alzheimer's disease has been starting silently in the background, unbeknownst to anybody. Okay? And what they seem to think happens in Alzheimer's disease is that bits of the brain cells somehow go wrong. Okay? There are two proteins, two bits of brain cell that they're interested in. So one is called amyloid. And amyloid is a bit of protein that just lives in the brain cell. And ordinarily what happens is as you sort of go through life and you sort of replace bits and tidy up your brain cells, ordinarily old amyloid gets snipped in two. The two bits are soluble, they dissolve, and you flush them away, and then you make some more. What seems to happen in Alzheimer's disease is when it gets snipped, they don't snip it in the right place. So whereas one of the halves dissolves and gets washed away, the other half becomes insoluble. So rather than it being like sugar in your tea, it's like sand in your tea. And so it gets stuck in the brain. The other thing, I guess, more like mud than sand, is it tends to clump together. So all these insoluble bits of amyloid tend to clump together and form plaques in the brain, which damage the brain cells. Okay, so that's one of the things that they think goes wrong. The other bit, there is another thing that's called tau. And what tau does is that lives inside your neurons, inside the brain cells, and acts a bit like scaffolding to keep them in their three-dimensional shape. And what seems to happen in Alzheimer's disease is they lose all their rigidity and they crumple up like a ball of wool. So rather than having a nice, firm scaffolding structure keeping your brain cell three-dimensional, it collapses down and you get a sort of a tangle of proteins. They're called neurofibrillary tangles. So they seem to think that what's been going on in your brain for a number of years before you get symptoms is you've been having formations of plaques and tangles which are causing neurons to die. And because you've got so many millions of brain cells, that actually you don't get symptoms for quite a long time. So by the time you're getting symptoms, in a way, it's too late because you've already lost so many brain cells. Okay, and the theory being that once they've gone, they've gone, and you're not going to regrow any new ones. Okay, so there is now, if you like, a current research is aimed at trying to get these things, these plaques and these tangles, before you get symptoms, or as soon as possible. And you'll remember, this is quite helpful that we've had COVID, because you'll know all about antibodies, because the news is all on about these antibodies that go around and eat up the coronavirus. Okay, so what they're inventing is they're inventing antibodies that are specific for amyloid or for tau. So you'll have an antibody that you will take that will get into the brain and will gobble up all the plaques. Okay, the theory being, if you can get these plaques before they damage brain cells and clear the brain of plaques, then it won't damage the brain cells and you won't go on to get dementia. Okay, they have all sorts of really, really complicated names. I've put them down at the bottom: bapineuzumab, solanzumab, aducanumab. They just do this. I'm sure they make them harder deliberately to confuse people. But the thing to remember is that they're called, these antibodies are called monoclonal antibodies. Monoclonal M antibodies, ABs. So if you have something that finishes in a MAB, it's one of these drugs that is there to eat the amyloid up before it causes problems. Okay. This is the worst slide coming up, so don't panic, everybody. Told you. Don't worry, I shall talk you through it. It's not as hard as it looks. Okay. So all you need to look at is going up this side here. You've got normal at the bottom and abnormal at the top. Okay. So what we're talking about, normal, is normal levels of amyloid, or abnormal. So the higher you go up, the more abnormal amyloid you have. Okay. And along the bottom, you've just got time. Forget the green, just look at the first red line. Oh, no. You see, you don't get away that lightly. If you look at this red, can you see my pointer, this red line here? Yeah, it's no good using my finger, you can't see my finger. Okay, so this red line is, if you like, a buildup of that amyloid plaques, buildup of the amyloid. So if you do nothing else at all, this is what would happen with Alzheimer's disease. The amyloid will go up and 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 up, and then eventually you would get Alzheimer's disease. Okay, we're only going to look at T1, this thing here is called T1. Okay, if they gave people their MAB, their monoclonal antibody here, then this is what happened. The dotted line is what happened to the amount of amyloid plaques there were. So it gobbled them up, gobbled them up, gobbled them up, gobbled them up, gobbled them up. Again, because of course we don't know, we've not stopped it from happening. We don't know why it keeps snipping. It's still snipping it in the wrong place, but it then starts to creep. So it starts to creep up again later. But it has put off for ages how high it gets. Does that make sense? It's a tricky one. But if you just look at the red and forget all the greens, and forget T2 and T3, if you just look at the red and the T1 and this dotted one, you see it goes up. They give you the antibody that eats the amyloid, so it goes down again, and then it comes up, but it has put off the time that it's been damaging the brain cells, so it delays the onset of Alzheimer's disease. And the idea being, if you keep doing this and you keep stop making amyloid, then you don't damage your brain cells, then you don't get Alzheimer's disease. Yeah, but of course, this relies on you getting diagnosed before you've got symptoms, or when you've very, very mild phases. And so all the treatment at the moment is looking for people who've got very mild memory problems, and then seeing if they can take these medications. The other snag with it, just by the by, is that whereas all the other stuff comes as tablets that you can take at home, this comes as an injection. And so you have to either have an injection into your vein, or they're working on one now that you can have under your skin. But if you were needing to have it as an intravenous injection every month, say, that would have huge implications to how Alzheimer's disease is treated. There you go. I'll get off this slide for you. Okay, things that you can do to help. Okay, this is the positive, hopeful slide. The first one is really, you should start living healthily from midlife onwards. Okay, diet and exercise, and the slogan is, what's good for the heart is good for the head. And again, there was a huge trial in America that had nothing to do with dementia. They were looking at heart attacks and strokes. And they found that people who were treated vigorously with their blood pressure, their cholesterol, and everything else kept under control, and they followed them up for years, and they found that, yes, those people who were in the treatment group, if you like, they did have less heart attacks and strokes. And then they looked again and said, and actually, on average, they developed dementia 5 years later than the group who just lived normally and carried on smoking and drinking and having fun. So we do know that being healthy stuff can delay the onset of Alzheimer's disease. Okay. As said before, if you are worried about yourself or somebody else, don't put it off. Okay, go and get it looked into, and then either you can be reassured that it's not dementia, or if it is, you can get started on the appropriate treatment, because we know that improves outcomes. If you are diagnosed, plan for the future. You know, it is possible to live life well and enjoy life with dementia. And lots of folks I see who I've given a diagnosis, and I see them 3 months later say, actually, it's a relief to know. I feel much better knowing than I did before, because the reality isn't as bad as I thought as I'd built it up to be in my head. Okay, sorry, I've overrun. This is the only other thing that you might want, again, useful, is the 0800 number at the top is for the Managing Memory Together service. And that's a free phone number that's available during working office hours that you can call up if you have any questions about dementia, or if you're caring for someone with dementia or think you might have dementia, they can give you advice. If you are a bit shy, don't want to talk to people, then there is also the email address that's down below, and you can just email them with any queries that you have. And I'll say thank you very much.